today. So for maternal and child health is actually the key determinant of the health of a society. And despite our very recent economic growth, if we look at the mortality figures for maternal and child indices, they're dismal. And not only just maternal and child, we're looking at infant mortality, under 5 mortality, neonatal mortality, and these figures are very dismal. The high infant mortality rate that we have is largely because of deaths that are happening at birth, and also the deaths that are happening in the first month of life, largely due to infections, due to early birth, like what we call preterm birth, or encephalopathy due to birth asphyxia. So why is it that we still, despite decades of research and a lot of hard work, these figures are not looking up? One of the reasons is that the disease is not understood enough to be able to give us effective solutions. And that could be because it's being seen from only one side. It's not a interdisciplinary or a multidimensional approach to understanding the disease. The second thing is that it's very critical that solutions are driven by the need of the society. So the discovery around a disease or discovery around trying to find solutions have to be driven by the need of the society, so that these applications can then go back into the society. And therefore, we've labeled our talk as interdisciplinary research for maternal and child health from bench to bedside and back. Now, at the Translational Health Science and Technology Institute, which Karthik introduced, is an autonomous institute of the Department of Biotechnology, Government of India. And here we've been working around early infections and preterm birth. And I'm going to take you through one of these examples of what we have been doing for the last 5 years now. Oops. So why preterm birth? As you can see here, the preterm birth complications constitute a large part of global infant morbidity and mortality. But even at home in India, you can see a large number of babies being born preterm. Many of them die soon after birth, constituting 35% of the total neonatal deaths. And not only that, we have long-term consequences for these babies in terms of cognitive disorders, in terms of medical problems. In addition, we're spending billions of money trying to look after the babies once they are born. And as I said, the effective solutions for preterm birth, despite decades of research, are not there, not only in our country, even globally. And there are many unresolved questions and key challenges. And that is because one does not know the fundamental processes which underline what we call the preterm birth. Preterm birth is defined as conventionally as babies that are born less than 37 weeks of the pregnancy, of the period of gestation. It's a complex syndrome. If there are physicians in this group, they'll understand that it is comprised of multiple etiologies: genetic, biological, psychosocial, environmental factors. And the current data that we have is compromised by the small size studies, by the phenotypic heterogeneity of these studies. And therefore, we don't have real data to say why is there a problem and can we find solutions. The available evidence for mechanistic pathways from small number of animal studies. And then mostly the studies that are available have done clinical and biological assessments as just snapshot evaluations. And that will not help us to find a solution. We need to understand the disease as we've shown here, not only just the clinical problems, the cell biology, the environment, the omics. So it's a comprehensive look, an interdisciplinary discovery, or looking at the disease, which is very important to find solutions. So driven by this societal need and driven by this problem, Department of Biotechnology, Government of India supported this mission program, which, as Karthik said, is nicely called GARBH-Ini, which is an interdisciplinary group for advanced research on birth outcomes, DBT India Initiative. Now, I'll just take a minute to describe this program, because not a study, it's a platform. It's a program which is meant to be, it's been identified as one of the Atal Anusandhan mission programs. And it's interesting because, it's a collaboration between research institutes such as ours, DBT Autonomous Institutes, coordinated by THSTI, but has other DBT institutes like the Regional Center for Biotechnology, National Institute of Biomedical Genomics in Kalyani. It has hospitals like the Gurugram District Hospital, which is our large collaborator, and other tertiary hospitals in Delhi, like SIDDHI Hospital. Then we have across these institutes different domains: epidemiologists, clinicians, genomics and epigenomics expertise, proteomics, people working on microbiome. And very recently, we have IIT Madras Data Science Group joining this collaboration. Along with, we have another very interesting collaboration with University of Oxford, the biomedical engineers. So this is a platform where we have set up an interdisciplinary group. It is driven by a hypothesis where we believe that pregnancy is modified by different clinical and epi factors across pregnancy. It is also a result of static, like the genomic factors, and dynamic factors like proteomics, microbiome, epigenomic factors, which will be different across different time points of pregnancy. And therefore, time series data collected on diverse variables across pregnancy will be able to stratify women into defined risk groups for preterm birth. As I said, once the baby is born, then we're spending millions looking after that baby. What we need to do is identify these women very early in pregnancy, or at least midway in pregnancy, or before they go into labor, to be able to say, yes, these are high risk. They need to be given special care to prevent that preterm or the early gestation. And therefore, the ultimate goal would be to get an effective risk stratification with modifiable and non-modifiable clinical factors, predictive omics, and image biomarkers, and eventually, using very refined modeling techniques, do an integrated decision algorithm for early prediction and timing of intervention of preterm birth. In addition, we have also created and augmented research systems like the data management and biorepository. So our ultimate deliverable is an algorithm for decision-making for individual and population-level risk stratification using interdisciplinary sciences, tools for more personalized and futuristic prediction of pregnancy outcome with both ultrasound using machine learning approaches, and adding to that biomarkers from omic-based technology, and finally also develop and augment research systems that can become national and global resources. So, as I said, an ambitious program. We've achieved some successes, of course, many challenges. We have now a cohort in a small district, hospital. So it's actually a hospital-based cohort. We have enrolled, our sample size before we started was to enroll 8,000 women. I'm not going into details as to why. The design is that we enroll them early in pregnancy, not later than 20 weeks, follow them across pregnancy, as you can see here, at different time points, up to delivery, 1 visit postpartum. We collect very detailed clinical history, so there's very accurate and detailed phenotyping of these women. Different types of biospecimens are collected from the mother, the neonate, placenta as well as the father. And then we are doing very detailed ultrasound across pregnancy to look at both fetus, placenta, as well as the uterine characteristics. And I'll talk a little more about that. So what we have documented, we have enrolled 8,500, over 8,500 women, documented over 7,000 end of pregnancies. We had a small glitch during the COVID break. And what we've documented very systematically for the first time in the country, that preterm birth is actually 13%. Whatever values we were getting till now were based on a lot of modeling. And this is what we've documented, along with high other adverse pregnancy outcomes, as in stillbirth, low birth weight, small for gestational age. And you can see, despite everything, these figures are still very high. And when we looked at the conventional clinical and epi risk factors, I'm not going to go into detail, but using very conventional research methods, we found many clinical factors which are known factors. But what came across interestingly was the use of biomass fuel and passive smoking, and I'll talk a little more about that, and of course maternal nutrition, which are risk factors for preterm birth. But if you can see here that using the conventional methods, the risk factors make up only 10% of the preterm birth, where there are at least almost 90% of unknown factors, where we don't know why preterm birth is happening. And we feel, and our hypothesis is that this can improve by using better modeling techniques. The other thing is adding predictors from omics and the ultrasound domains, and actually looking at good phenotyping of the preterm birth, which I said is a multi-etiology complex syndrome. And therefore, to be able to get actual prediction, you need to have accurate dating. Remember, I said it is 37 weeks. So it's one disease which is based on a length of, it's based on a number and on a length of a gestation, to be able to get accurate phenotyping. And therefore, within this phenotyping, you can then do good prediction. So as I said, you need to get the dating of pregnancy most accurate. And the dating conventionally is either done by taking the mother's last menstrual period history, which is again depending on the mother's recall, or using the ultrasound based on the fetal anthropometry. And this is difficult because, as I said, you need to have very specific PTB phenotypes before you can actually start predicting. And therefore, these complex relationships between the predictors and outcome, non-linear relationship across pregnancy, clusters of risk factors, we were actually at a loss at that time, and we weren't sure how to move forward. You know, we'd done all our conventional analysis, and that's the time when we reached out to our current collaborators at IIT Chennai, and Himansh, he's here, he is moderating the session. And we needed people who could understand the disease, but could also understand how to analyze that data along with us and move forward for accurate predicting. Again, because of constraints of time, Karthik and Himanshu, I request you to tell me if I'm overshooting. So the first thing was to get the date right. And as I getting the dating right. And usually when the women come in the first trimester, which is before 14 weeks of gestation, that's the time when you actually say, okay, this is the period of gestation. And based on that, the entire pregnancy is monitored. And these formulae are all Western formulae. What we've been using are Western formulae till now, and they've not been evaluated in our setting. So what we did with this collaboration was to actually develop our own formulae, which could be used in the ultrasound for accurate dating. And as you can see, these are all the formulae that have been used till now, but we developed based on our local anthropometry and found that its sensitivity was higher, the specificity was equivalent, and its accuracy was higher. So the GARBH-Ini dating formula, which was a quadratic module, and I'm not going to go into the methods because Himanshu can answer those questions after this session. But just to give you a flavor of what we were doing, we now have a dating formula based on the local Indian anthropometry data of the fetus to develop this formula, which can actually, once validated, be put into clinical practice and make a huge difference in clinical practice once we move forward. Now but there was a problem. Nearly 30% of pregnant women in India make their first antenatal visit beyond first trimester, which is beyond 14 weeks. And late trimester, when they come in towards the end, many of them just come in the last trimester. And at that time, that's heavily dependent on fetal growth. And that's an underestimation of preterm birth. If the fetus is small, the anthropometry will be small, and therefore the prediction will not be correct, and therefore your phenotyping is also, the phenotyping won't be correct, and therefore your prediction will not be correct. But what we have now is a first trimester dating as the gold standard, and we moved ahead to use anthropometry of the fetus. As you can see, these are the various parameters of the fetus, the biparietal diameter, the occipitofrontal diameter, all these various parameters. And we tried to see if we could get parameters which were not dependent on the growth. And this is what we have now. And as you can see, using a random forest model, we've got all these parameters which have gone into variables in order of importance. And today, this formula with the second and third formula is for second and third trimester, as you can see, is performing better than the Western formula, about 45% in the third trimester and about 20% better in the second trimester. Of course, this is initial data. This needs to be validated in another subset of women from the cohort and even external cohorts. So this is the group that has worked very hard on it. And then we come to, can we define the clinical phenotypes? Here again, a lot of data-driven methods have been used by using various clustering methods. And I'm not going to go into details because this is very initial data, but just to explain the complexity to you people, that it's not just simple one phenotype, it's a complex phenotype. And it's like if you were to talk about coronary artery disease. Coronary artery disease has many, many facets to it. So its preterm birth is like a complex syndrome. You cannot predict the whole syndrome. So therefore, if you can pick up specific phenotypes, your biomarkers and your interventions for that specific phenotype would be hugely helpful. And therefore, then we come to the predicting models. And here again, my colleagues who have been working on data science, they've been able to develop these prediction models, again, very early just now. And I can only say that they have, what I've understood, I'm a clinician, but staying with Himanshu's group and a lot of my data science colleagues, I picked up some of this. And that's the beauty of working on an interdisciplinary platform, that you cease to be just a clinician. You're actually looking at very many multi-dimensions of the whole thing. So here is, you have a baseline. So in this model, you have baseline predictors with some, which have, you can see the ROC curve here, the data, which is not great, but as you move forward, this keeps improving, and it's still not the best. It's only 0.75. And so it again brings up the point that with our clinical parameters, some of the ultrasound parameters, we need to have many more parameters in the prediction model to get a final one, which will help us to develop what we aim to do. And so very quickly, whatever omics that we have now. So as I said, we had ultrasound images, and I've defined a little bit on that. Then we've also been collecting sera to see if we could pick up the biomarkers, which were largely based on omics technology. But before differentiating between term and preterm, so just a little bit, what we have available just now are biomarkers, which is when the woman has come in labor, which is really not going to help prevent preterm labor. Then you're actually working on how to manage that baby once that baby is born. But what one is attempting, and not only us, there are a couple of global groups, cohorts like us, where we have harmonized some of our variables, that are there markers which you can pick up these women earlier in pregnancy. But to be able to understand that, we need to know what are the protein excretion in women across pregnancy, what are the epigenomes in, across pregnancy. And therefore, based on that, we now have some candidate markers which are coming from the saliva and from the high vagina, which one can see across normal pregnancy. And what we have now started is seeing a comparison between term and preterm, and some very interesting data is emerging from that. Similarly, we found that looking at the antenatal epigenomic alterations, there are 254 differentially methylated CpG sites from promoter regions of 251 genes in mothers who have preterm birth. So there seems to be a difference between women who are delivering early as compared to those who have term deliveries. We are also conducting a GWAS, where we are studying genetic variants for association between quantitative outcomes like gestational age at delivery, birth weight, placental weight, and blood flow. And very recently, very interesting data on looking at the microbiome of the vagina in these women. And not only have we found across pregnancy what is the predominant lactobacillus that is there now in women from our subcontinent, we also have specific lactobacilli, which are seen higher in term samples in third trimester of pregnancy, and specific microbiota seen in the preterm birth sample. So when we look at this further, more functional work is being done on this, we can actually use it as a therapeutic target, because if these are actually making a difference to the gestation, they can be developed into therapeutic targets. This is looking at AI, and we've got again an interdisciplinary group, and we are working on of course accurate prediction models and early risk stratification using AI from the thousands of images that we've got across pregnancy. We have now developing a software which can automate these measurements so that they can be independent of the operator. So, and as you can see that in small hospitals where you are not getting trained sonographers, actually developing these automated measurements will make a huge difference. And we're very excited about this, which we're doing with the University of Oxford, is to develop a computer-assisted low-cost point-of-care ultrasound, which is largely where you have these video sweeps, which using AI are getting will get translated into a decision algorithm, which can be used for triaging in resource-limited settings. Then a few public health messages that I'd like to give is that, when you're following these women, we really don't know how these women are nutritionally compromised. We all know that they are nutritionally compromised, but to what quantity? What is it that our women lack? And why is it that we have such high fetal growth restriction? Why is it that we have so much preterm birth and small for gestational and low birth weight? And what we found, again, for the first time in the country, because it's the first cohort which has systematically followed such a large set of women across pregnancy, that 50% of them do not gain recommended weight. And 1/4 of our babies are born with growth restriction. And so we're actually working on maternal nutrition, looking at what are the dietary clusters, what are the nutritional parameters, and trying to associate them with the micronutrient status, the protein quality, the metabolic disease, and ultimately trying to associate this with fetal growth and early gestation of pregnancy. So at the end, we hope to have comprehensive evidence-driven dietary advice to optimize outcomes. And as I showed here, the gestational weight gain, as you can see here, this is in comparison to the global standards. And as you can see that our women are not gaining as much weight as they should be across pregnancy. And in the early part of pregnancy, they seem to be fine. And it's only towards the latter part that they start showing a fall. And that is what is worrisome, because that is what will be influencing the fetal growth. And these are parameters that we need to evaluate further, again, for interventions too, so that this can be prevented. And here, just to show that early BMI influences the gestational weight gain. And so, when we have women with a very low BMI, their gestational weight gains will be influenced. Okay, so my couple of my last slides, where this is something that would interest many of you, is that if you remember, I said one of the risk factors that we had was history of biomass fuel and passive smoking. But that was documented history. We don't have quantitative measures to that. And therefore, again, in collaboration with IIT Chennai, we started this program on trying to study what are the critical windows of vulnerability during pregnancy and the dose response of air pollution exposure, which could be associated with early gestation and fetal growth. So we've, in collaboration where these monitors have been developed for satellite monitoring, for multi-pollutant monitors, which are low cost for picking up individual exposure, and also household microenvironment measures. And what we have done is actually done a temporospatial map this is mapped the air quality in that locality. And now if you can, if I go forward, the plan is to see in 1,000 participants, what is happening at the individual level, the exposure in their ambulatory state, in the houses, and then following them up to see how it affects the babies. What we will have are critical windows, the windows which actually this may be an important factor. Is it mid-trimester? Is it late trimester, which is affecting the fetal growth and early gestation? So what is it that where we need to go in and intervene? What is the dose response? Is there a dose response relationship with the exposure and the outcome? And this, I said, is being done with Dr. Raghunathan Rangaswamy from IIT Chennai. And this has been really very, very useful. So, this is, I can go on and on, but given the brevity of time, so we realize that you can keep adding layers. It's a platform. It's meant to be a national and a global resource. And therefore, the next thing was that we did have so much data. So we need to build a biorepository and an imaging data bank, and then use this to develop new hypothesis-driven studies where we can encourage younger investigators, which we have now, a few of them, to come and develop their own questions, use this data, and to move forward. And therefore, just to say, this is a program which has been started by my colleagues Ram and Condi. It's called the Faridabad Data Science and AI Program. So we have a very well state-of-the-art data management. All our data is electronic capture. It comes into so it's captured at the clinical site, but it's all stored at at THSTI. We have all automation and quality assurances in place. And now with this new program on Faridabad Data Science and AI program, we are moving towards handling large data. And of course, we have a state-of-the-art biorepository, which has over 13, over 10 lakh samples now. And we have already started sharing some of them. Of course, they are meant for answering some of our questions, but we are initiating a process where data sharing can happen. And of course, as I said, there's an ultrasound image repository of longitudinally collected images, which again are a platform for encouraging a national and global platform. And of course, as I said, this would not be possible if we didn't have these teams in place. Again, one slide is not enough to show everybody, but just some of the key teams that we have there. So I think I'll conclude with that. Thank you very much for giving me this opportunity and giving us an opportunity to be able to present this. Thank you very much. Himanshu, over to you.
Yeah, hi, thanks, Dr. Shinjini. That was, I think, everybody would agree, was quite different from many of the SIDDHI talks that we had, where we are looking at one of the pressing healthcare issues that has been long not addressed in India, and something that really needs to be addressed in order to ensure that the future of Indian population is healthy and starts very early, as we see. So what I would do right now is actually take a look at if there are certain question answers right now. No, there are none right now. So maybe I can start here. Dr. Shinjini, you had mentioned that the preterm birth rate is a complex etiology, that and you sort of gave certain factors that contribute to it. So if it is a complex etiology and hasn't been like solved anywhere in the world, so what are the challenges that people did not like that they had, that we haven't been even able to solve this? Let's say, for example, in developed countries like in Western Europe or in US. Dr. Shinjini?
Yeah. So I can see that question, that somebody said that they didn't know that there was such a huge percentage of unknown reasons. Well, actually, it's true. Preterm birth is being classified as just the gestation, that 37 weeks less is preterm birth. But there can be different types of clinical severity of preterm birth, which is again by the length of duration, which is like moderate, severe, and mild preterm birth, or you can have it by the kind of preterm birth, the way the baby presents. And if the clinicians here, they'll understand whether it's a spontaneous preterm birth, is that with the membranes have ruptured or have not ruptured. So what is the problem with preterm birth has been that because it has so many different etiologies, one doesn't know if it's the infection which causes the spontaneous preterm birth. Is it infection in a predisposed woman which causes preterm birth? Is it that there is a fetal cause which could be causing that preterm birth? Actually, really nothing much is known. And that was the reason why today there is a global effort to find out what really comprises preterm birth. That's one thing. The second is that we may spend centuries trying to find out the complex etiology of preterm birth. The other smart way of doing it is to actually categorize them into specific phenotypes and then possibly look at some of the more easily achievable phenotypes for targeting for interventions. Could it be that in India, a large proportion of them have a preterm birth, which could be with the duration, with rupture of membranes, with a genetic predisposition, with a particular proteomic landscape? Could there be biomarkers for this specific phenotype? That's the challenge. You cannot find all you cannot find one solution for the entire syndrome. It's not possible. And that is why it's very important to understand the phenotype and also understand the risk factors with each phenotype. And that's where multiple
Dr. Shinjini, I think you're muted right now.
Oh, sorry. Okay.
Yeah.
Did you hear my
No
last?
worries. Yeah, that's okay. So there is a question by Anupama. She's asking, do we have a monitoring system regarding all the deaths in specific region or states that hints that specific nutritional interventions for pregnant women? That's the statement. Wouldn't that help? That's a question. So I think the question is whether specific nutritional interventions of pregnant women would help in reducing neonatal deaths. Do we have any monitoring system such as like that in India?
Oh, yes, of course. There are many monitoring systems, and women nutrition is being monitored all the time in the peripheral hospitals, in the villages, in primary health centers, where they are being given the micronutrient therapy. Their weights are being taken, their BMI is being monitored. All that is being done, but it still, as I said, is a challenge because we don't have enough answers to be able to say, why do we still have, as you saw, 28% women, almost 30% of small for gestational age, and almost a quarter having low birth weight. So, this is a challenge. And this is despite huge effort by the government to look at maternal nutrition. And therefore, it is not just looking at maternal nutrition, it's actually understanding the disease, the nutritional status. Why is it that the micronutrients, even if they are being given, not making a difference? What is the biology behind it? Is there something more?
Is it genetic, or is it? Yeah. So there's another question by Vinay. He's asking, what is the role of gestational diabetes in preterm birth? And with India being a large diabetic population, could that be a contributing factor? So gestational diabetes and relationship with preterm birth, that's what's being asked.
Yeah, and Himanshu, you would also remember that we've done some work on this together. So we found, surprisingly, again, because we were monitoring these women in the cohort, in some of the hospitals, the best way of picking up gestational diabetes is by doing a glucose tolerance test. And we realized that this was not a standard of care in the hospital that we are working with. And that's largely because if you see the caseload, and with the kind of caseload these doctors are getting, it's very difficult to do everything that is supposed to be done as standard of care. And so very often gestational diabetes is missed so we've been trying to do, and I'm glad you brought this up, because what we found is that it's above 15%, almost, if I'm not wrong, it's almost 18% of gestational diabetes that we've seen in our cohort, though we've started looking at it only very recently. And again, that's an area, of course, it affects the baby. It will affect the baby in many ways. Hyperglycemia is going to affect the baby's growth. It can cause an overgrowth. It can cause early gestation. It can affect the mother's metabolic status, to affect the mother after pregnancy. So there are many conditions by which the mother can be affected. And at the moment, GTT is the only, glucose tolerance test is the only way of picking it up. And therefore, that's another area of work that we're looking at. What are the easy diagnostic methods of picking up gestational diabetes in women?
There's another question. Is there a gender specificity to PTBs, or does it contribute like male and female? I don't think there is one, if I'm not wrong, right? There is.
Not seen that. Yeah.
So what about?
What is well known is that if the mother is a preterm, has been preterm herself, then is more likely to deliver preterm birth. If she's had a preterm birth earlier, then she's more likely to have twin pregnancies, would be more predisposed, but there isn't really a gender specific.
Okay. What about thyroid level? Is there a connection between thyroid level and preterm births? That's one other question that has come up.
There isn't very hard evidence on that, but we're looking at TSH in the neonate to see if that is affecting the cognition of, but there isn't, we don't have data on TSH, and there isn't really hard evidence on that as such. Yeah.
Okay. One interesting question from, I think, one of our students here is like, human microbiome, specifically of uterine or endometrium microbiome diversity, can that be used to predict preterm birth? And I think you have high vaginal microbiome, but not uterine. Uterine would be impossible to get, right?
No, it's not possible. We're not even taking the cervical microbiome, because that can be invasive for a pregnant women. So we are taking only a high vaginal swab. And as I showed in my data, that there are some specific lactobacilli which are being seen more in preterm, as there's a difference in the kind of bacteria we're seeing in term versus preterm. And now we're doing the functional metagenomic studies on that. Further, we will validate this in a larger cohort. So whatever I've shown is all part of a discovery data. What we have to now actually look at all these results, validate them in the next lot of women that will get enrolled, and also external cohorts. And we plan to do that in the next phase.
So another question from Tina is that,
answering that question, Himanshu, yes, If we find a difference, which again shows a significant difference as we move on in the validation, there will be an interesting target which can be used for therapeutics. Yeah.
So one question from Tina has been like, can hypertension and preeclampsia contribute to preterm birth?
Yeah,
sure.
Yeah, absolutely. That's a known cause. So I should have specified that what we are working on is largely the unknown causes of preterm birth. Hypertension, preeclampsia, all known causes because they cause placental insufficiency in some ways. But having said that, there's still a lot of lacunae and a lot of gaps even in that work because people are still working to find solutions.
So one, like this is a data collection question. So Dr. Sudarshan from IIT is asking, what are the challenges in collecting data about preterm birth? What are the ethical, social issues that come up in collecting this kind of data? Because this is sort of, in one sense, a personal data, and we as clinician, as a cohort coordinator, what were the challenges when you started this cohort?
No, so the challenges, this is pretty much there for any research study, whether it's a cohort or a randomized control trial or whatever study that you may want to do. There are processes in place where you have to go to the ethics committee. So if the consent from the participant clearly, firstly, we have ethics committees at our institute and all the participating hospitals. So we've actually gone through 3 ethics committees for this kind of data collection. The challenge, I would say, is not with the ethics committees, because if your informed consent form is well structured, it's clear, transparent, telling the participant that this is the data that we are collecting. This data will be used for this purpose. So we spend almost an hour and more trying to explain to the participant that this is the reason why she's getting enrolled in the cohort. Then they're given a participant information sheet. She's asked to read that. It's in the language that she's familiar with. She takes that home, she reads it out to her family, and only once she's comfortable is she asked to, that she gives consent to participate in the cohort. There's any point in time, if she refuses a sample, refuses an ultrasound, refuses any data, we do not take it. The other thing is that we take a global consent from them. It's that we explain to them that this data is going to be used for research purposes, will go into a biorepository or an image repository or a clinical data bank, and can be used by a researcher for any other research. And this is done right in the beginning. So now, when we are using it for additional questions, we do have global consent, provided the ethics committee is comfortable with the question that we are asking. It is a challenge because we have to keep the participant on board all the time for whatever we are doing. There's nothing, I think it's just transparency, which is important.
So I think
answer his question.
Yeah, I think it does answer. As I've also seen your cohort going on at Gurugram Civil Hospital, it's a actually hats off to people who do these kind of studies, because as data scientists, we really do not have any clue how the data is collected, but data collection is one of the biggest challenge, and getting clean and accurate data is a harder challenge, as all data scientists would agree. So I would request Professor Murali from IITM to directly ask his question. He's on a panelist here. So Professor Murali, can you ask, please? Professor Murali? Yeah.
I have not posted any question. Are you seeing me? I have not posted any question.
So you wanted to ask a question. Is that?
No,
your hand was raised, so we were
wondering if
maybe by mistake. I'm sorry.
Okay.
Sorry for that. Sorry.
No worries. So there was another question. So I think that is one of the questions being asked by Rahul, is there a connection between baby growth and preterm birth? I think you have addressed that in your last slide, that there is a definite, like as the baby size is, like fetal growth is restricted, preterm birth rate increases.
You can imagine the challenge. You have a baby who is restricted in growth and is a preterm birth. There are huge clinical problems with such babies, not only at the time they are born, but at the time they are, as they grow up, and the consequences that this has on them is huge. So it's not just about being born preterm. It's also being born with the kind of growth potential is important.
So there is one question I'm actually no clue. So does organization like FOGSI work together for data or for understanding? What is FOGSI?
This must be the OBS and gynae. Okay, so I'm not a gynecologist. I'm a pediatrician, but yes, they must be working with many other research groups. We don't work with them, but it is very important to keep these groups on board. Like, at the end of the day, the data that we have, we'll share it with our pediatric fellows, the Indian Academy of Pediatrics, with other practicing clinicians, because they are the real stakeholders for this data. So yes, I would say that they should work together, and they are working together, but we are not working with them. We are working with other organizations. Yeah.
So there's an opposite question. So if the growth of the baby is perfect, what is the chance of PTB? Is it less or is it unknown? Like, if the growth of the baby is normal, or what are the chances of PTB? Is it like less or is it normal, like same? We don't know, right? That's the challenge again. Right.
So there's so many phenotypes of preterm birth that the baby may just be born early because the mother had some problem, and there was no problem with the fetus, no problem with the placenta. So you can imagine the fetus is compromised, there may be preterm birth. The mother is compromised, there may be the placenta is compromised, there may be preterm birth, or it may be a mix of all three, or two of them, or one of them. So it's just very complex.
So there's one more question. Is there any study on efficacy? And I think that would be the last question. Is there any study on efficacy of such pregnant women nutrition intervention schemes being done? I think there are several studies.
Many studies.
Yeah.
But again, those studies of the solutions that are there are not being, they're not implementable or sustainable. And largely the problem is happening because the disease as such is not being studied in a very comprehensive manner.
And as you said, like PTB is a complex, so we really don't know whether it was a maternal nutrition factor that contributed to PTB, because usually all of the studies, as I think that have been done till now, are what are called endpoint studies, where you have a preterm birth and then you start sort of trying to understand why it happened, rather than like a study like your cohort.
No, but there are intervention studies in the mother to look at preterm birth. There have been micronutrient interventions, there have been dietary, all that has been done. And that's why I said, despite decades of research, we still don't have effective solutions. Yeah. So that is a, yeah.
So I have a question directed at, both of you. So for students, there are a lot of students on this call, and there are a lot of students who will eventually try to do some sort of internships in these kinds of projects and things like that. And I know that you and Himanshu have both worked with a lot of young students trying to analyze this kind of data and things like that. So do you have any sort of pointers for them as to what kind of, I think you've interacted with students from different backgrounds. So is there any restriction on the kind of students who can come and work in this area and things like that? And what kind of backgrounds are more desirable? I think Himanshu may also have a lot to say on this.
Himanshu, should I go first or you'll
Yes,
go?
please do. Yeah.
Okay, so no restrictions, no borders. Everyone is most welcome. The question has to be good. The question has to be driven by something that we really need to answer. And we would be very happy. We have some really, Ram they must be in the call as well. Ram, Kondi, my other colleagues, they're all very, very happy to have students. And we already have an internship program. It's very informal. Himanshu knows that. And I must say that when I came to IIT Chennai and I came and interacted with Himanshu students and Karthik, your students, it's such a pleasure, because it's nice to I mean, the Himanshu's group now actually understands what trimester dating is, what are ultrasound, what is anthropometry. I'm sure they knew nothing about this, and I knew nothing about how do you develop models for dating. So it's been learning across groups. It's been fantastic.
No, so just to complement what Dr. Shinjini said, like if you look at the students that have come to my lab to work on this kind of data, first few students were from biotechnology, as obviously because there was no information outside the biotechnology department. But I have now one student from mechanical engineering who's developing risk models for preterm birth. And I do get several queries from other students from other departments as well. So there is, so as she said, like there is absolutely no barrier. One just needs to understand the problem. There has to be some, like there would be some learning curve that one would have to, because the terminology is something that they would need to get familiar with. Otherwise, whatever they build, whether it makes sense or not, they won't be able to figure it out. But otherwise, I think there is absolutely no barrier. Data is data. The question, as Shini said, it's the question that is important. Once you have a good question, you should be able to solve it, whatever stream of training you are from.
So this is usually the prerequisite I say for my course as well, right? Just an interest and curiosity in biology. Exactly. You don't have to be good at biology. You need to be passionate about biology, but you can do your math and you can try to ask all the interesting questions and try to answer them.
Yeah. So I think it's the end, right? It's 7:30.
I really feel that that's the way forward. You know, we are not going to be able to answer these questions by just sitting in our silos. So you really need to have people working across disciplines.
Yeah. I think it's time for my word of thanks, and thank you very much, Professor Shinjini Bhatnagar, and also Dr. Himanshu, because such an important topic plus also extremely, specialized. And we need an excellent moderator to actually really be a via media between people like us who are, commonplace and then a very expertly done talk. It's a great honor for us to have you, madam, on National Science Day. And I also learned a lot of, concepts, probably which I might not be using it, but since I also work on this area of data and ethics, especially data science and ethics, and we're also working on some of these social justice issues with respect to how the data is used and other things. That's why I asked this question about the challenges faced, not purely in terms of collection of data, but also in terms of as a practitioner, as a clinical practitioner, and also a researcher, scientist, and also a policy person in many ways, right? So it's a very interesting combination of expertise that you have. Not just purely a clinician, not only a researcher, it's everything put together. That means the complexity even becomes higher, and it's much more complex to negotiate this. Because I just looked at the news, and there was a very interesting mention about the Tuskegee studies, and how Dr. Fauci was actually referring to it, or he was asked to explain how this was different in the current context, since there is a lot of vaccination hesitancy among people in the US. So I just, some of these questions never seem to die, right? So as almost 70, 80 years later, the questions keep coming back. So we know that now that with all the ethical committees, ethics committees, several rounds of ethics committees, and we have very important, safeguards to kind of look at many of these, initiatives. Thank you very much, Professor Shinjini, and thank you very much, Dr. Himanshu. And then we have a very interesting series of webinars coming up in March. This is actually African Asian Rural Development Organization. So we are actually conducting rural development, agriculture-based technologies that IIT has produced with rural RUTAG, and then RTBA and many other organizations that are affiliated with rural development and technology. Thank you very much, all of you, for the participants who participated in this webinar by Professor Shinjini Bhatnagar. Excellent webinar, and also an excellent moderator, Professor Sinha. And we will see you next time when SIDDHI hosts a webinar. Thank you very much to Professor Karthik and the entire SIDDHI team, Ujjwala, Lisa, Rudra, and Naresh. Thank you very much. See you next time.
Thank you.
So long. Yeah,
bye. Bye-bye.
Thank you all.